Today, again, a very important tip under discussion, that's acute headache. Headache is the most common presentation while you're working in emergency department. It can be a sign of any disease or can tell you or can be a manifestation of a very serious illness, life-threatening injuries. So let's talk about acute headache. First, we'll talk about immediate evaluation and management. In this slide, I'll give the algorithm or steps to how to identify and what to do when you see a patient with headache. Moving on to complaints of headache, ask the patient for any history of trauma, because head collision, especially in road traffic accident, is very, very common. So patient can present to you with headache post-trauma. So you have to ask if there is a history of trauma or not. If there is, you have to evaluate accordingly. But if there is no, ask for a seizure. If there are any generalized tonic-clonic fit or any abnormal body movements with headache, this can tell you a lot of information, life-threatening problems. For example, new onset of any cerebral vascular accidents, intracranial bleed. It can tell you about meningoencephalitis, many other serious illnesses that can be identified with headache and seizures. If there is yes, treat accordingly. If there are no seizures, look for any focal neurological symptoms. For example, any part of the body that's not moving. Or do you feel any numbness? Or the patient feel any decrease in power, decrease in tone, or reflexes? That's a sign of focal neurology. So that's a manifestation that headache with focal neurology is something to be taken care of, because there is a problem, something inside the brain. Because that is where the problem is coming from. If there is, go for a CT scan or MRI or angiography. Because why angiography? Because you can see a patient with headache and signs of focal neurology. Think of intracranial bleed, intracranial hemorrhage. It can present to you with headache. Angiography is very, very important in these cases. CT scan is diagnostic in patients with intracranial hemorrhage within first 12 to 24 hours. MRI, on the other hand, is very diagnostic of ischemic stroke. You have to identify what causes the patient the headache. If there is not any signs of focal neurology, ask for, is this any new headache or worst headache of life? If a patient says, this is my worst headache, I never had this headache before, or there was a series of gradual onset of headache in the past few days, but in the past one day it's been exaggerated to extreme, and I cannot really tolerate it, and never had this headache before. I've been going through some mild headaches in the past, but not this like this. This is a clue. Worst headache of life, rule out first subarachnoid hemorrhage. So if there is no signs of new headache, or the patient is going through some chronic mild headache or have a previous episode of such headache in the past, that's a chronic headache. That's other reasons to deal with, like that's a stable pain pattern. It's not an emergency. It's a chronic pain. It's not an acute pain. Think of migraine, tension headaches, sinusitis, TM, temporomandibular joint disease, cervical spine disease, analgesia, and referral to outpatient care, referral to pain management or concerned department. So, till now, we have identified when a patient comes to you with headache, what questions do you need to ask? What things you need to probe in? History of trauma, history of seizures, any focal neurology, the onset of pain. Let's continue. If the stable pain pattern is not there, the pain is gradual in onset, it's from the past couple of days, but now it's been at the extreme, a peak of the pain, and never had this pain before, you have to move to some other acute and emergency conditions. For example, signs of meningeal irritation. Signs of meningeal irritation, what includes photophobia, altered mental status, neck rigidity, or it's a nuchal rigidity. What to expect in these patients? Meningitis, meningoencephalitis, subarachnoid hemorrhage. Meningitis and meningoencephalitis at times can present to you with a history of fever or history of lower respiratory tract infection before in the recent past. Think associated with any photophobia. Subarachnoid hemorrhage, on the other hand, can present to you with sudden onset of pain with no prior history of any fever. History of fall. Patient with multiple comorbids, for example, hypertensive emergency. But end-organ damage can present to you with subarachnoid hemorrhage. See, these are the emergency conditions. You have to identify these and you have to realize that these are life-threatening and these are curable diseases. So with your decision within prompt time can help save patients' life. So what to do in these kind of patients? When you're suspecting meningitis and meningoencephalitis, blood cultures, lumbar puncture, cultures and microscopy. Look for HSV. Look for multiple bacterial organisms that can cause meningitis and meningoencephalitis. CT scan if focal neurological findings are present. Antibiotics for meningitis and hospitalization. These diseases will be taught in detail in the next lecture, but for now, this is an algorithm how to approach a patient with headache. What are the important things you need to ask? You can ask many things about the headache, but being an emergency physician, you have to realize and you have to dig out things that are life-threatening and can cause severe problems. So in this slide, I have focused on things that can cause problem if they're not treated adequately and timely. So signs of meningeal irritation, as I mentioned before, photophobia, nuchal rigidity. Think of meningitis if there is a history of a fever. What to do? Blood cultures, lumbar punctures, and other diagnostic tests, which include CT scan, antibiotics for meningitis, and this patient needs an ICU care. So, if there are no signs of meningeal irritation, but the patient is with headache, hypertensive crisis. Hypertensive crisis rarely but can present to you with headache. Preeclampsia, hypertension, headache in patients who are pregnant can present to you with headache. When patients with headache, hypertension, and are pregnant comes to you with signs of headache and other problems, think of preeclampsia. And these are life-threatening problems. You have to save the fetus or the mother. So treat the patient accordingly and consult the relevant department on this. So if there's no chances of or no signs of hypertensive crisis or preeclampsia, look for signs of temporal arteritis. How do you look in that? Elderly male, most likely more than 50, with temporal pain or temporal pain with vision loss. Think of giant cell arteritis or temporal arteritis. So what to do with this patient? Hospitalize the patient, temporal artery biopsy, and steroid therapy. Moving on, if there are no signs of temporal arteritis, look for pain or inflammation in the ear, eyes, or sinuses. Headache due to paracranial structures. Think of cavernous sinus thrombosis as well. Treat accordingly. An appropriate specialist should be called on. Okay, one more thing. If multiple patients of same, for example, a patient comes to you who live in multiple patients come to you who live in the same house and they present to you with headache, and especially in winters when the gas heaters are going on. So what to expect? Multiple patients from same site? Think of carbon monoxide poisoning. With fire that's not been completely burned, they excrete carbon monoxide. These can cause headache and dizziness. And this is also a life-threatening problem. So treat according to the toxicity. What other causes can cause headache? Viral syndromes, post-traumatic headache, trigeminal neuralgia can present to you with headache. So in this slide, as I mentioned, this is a pathway to approach a patient with headache. What questions you need to ask? History of trauma, history of seizures, focal neurology. What are you doing by asking these questions? You are probing the life-threatening problems. That's how you approach a patient with headache. Headache itself can be a life-threatening many times and cannot be life-threatening. It can be a sign of many other diseases. For example, simple fever can present to you with headache. When you wake up, you tend to have headache. Decreased sleep can present headache. Mental stress or mental trauma or emotional turmoil can present to you with stress, with headache. But are these life-threatening injuries? No. What to do? You have to pick out or dig out life-threatening injuries, which can affect multiple organs and vital nerves that communicate your external organs with the brain. So moving on, the history is somewhat dissimilar what we have studied till now. But a few more important points to ponder or to look into when you ask a patient some specific questions related to headache. For example, as I mentioned before, any trauma, history of trauma, head trauma, have seizures occurred? Because seizures can be a sign of very serious underlying disease. For example, subdural hematoma. So these are signs which these are the questions or history points that can make you identify any life-threatening problem underlying with these symptoms. So any focal neurology, for example, patient present to you with new focal neurology with headache, especially if papilledema is present. This can present to you with mass lesions, underlying any mass lesions, any herniation, brain herniation. These are very important questions and very important aspects to be addressed when you're thinking of headache with severe diseases. So headache with new onset of focal neurology, think of a mass effect. And if papilledema is present, think of a mass effect. Think of any tumor, hematoma, or any abscess. So, is headache new or of acute onset? Why is this so important? A new headache in a patient without the history of any headache prior is a warning sign, is a red flag sign. Why? The patient who presents to you with worst headache of life, think of subarachnoid hemorrhage. And these patients need prompt investigations. So, what did you understand just with simple question? Subarachnoid hemorrhage can present to you with worst headache of life. Although it can be with some of the things, but you have to identify first the life-threatening problems, the severe, complicated problems first. That's how you treat the patient in ER. Is the plane consistent with meningitis or meningeal irritation? Subarachnoid hemorrhage can present to you with signs of meningitis, signs of fever, irritability, photophobia, any seizures, fit-like activity, recent any respiratory tract infections, any past history of meningitis. Think of meningitis. What you have to do, you have to go for cultures, antibiotics, empirical antibiotics, lumbar puncture, and further more investigations to rule out meningoencephalitis. And these patients needs ICU care. So, is headache due to hypertensive or preeclampsia or eclampsia? Ask the patient about the history of pregnancy, for example, in females. Females are common with migraine. Females present to you with headache most commonly in emergency department. But in a pregnant female with signs of hypertension and headache, Think of eclampsia and preeclampsia. It can move on to seizures. You have to treat adequately and quickly. Specialist of the concerning department should be on call, should be asked to evaluate this patient. These are very life-threatening and important questions which can tell you much information about the underlying disease. So moving on is this patient with temporal arthritis. As I mentioned before in the previous slide, an elderly male present to you with temporal headache, with vision loss. Think of temporal arthritis. What to do in ED? You cannot perform a biopsy, no, but what you can do is you can give this patient a steroid shot. This can help relieve the symptoms and help the disease progression, to reduce disease progression. Important point. Is headache due to disease in paracranial structures, for example, eye, ears, nose? Sinusitis can present to you with headache. Eye can present to you with headache. Acute glaucoma can present to you with headache. Cavernous sinus thrombosis can present to you with headache. There are multiple things. DST, dual sinus thrombosis, can present to you with headache. So these are the questions that you need to ask. Headache is not always with the internal structures in the brain. It can be due to some other structures outside the brain that can cause headache. From common to complicated problems, they all can present to you with headache. So are there multiple patients from the same vicinity? Think of carbon monoxide poisoning, especially in winters where the gas heaters are used at homes. How this occurs? Inappropriate or carbon monoxide production from the fire or the heaters can present to you with carbon monoxide toxicity. How do they present? Headache with dizziness. So a few more important points while dealing a patient with headache, what you have to ask in your history from the patient. For example, time of onset. Chronic headache are not always serious or are not complicated or are not life-threatening all the time. But the new onset of headache, with headache or focal neurology or some other signs, is a complicated thing and needs a prompt investigation. Headache in the early morning while you wake up, which makes you wake up. A patient wakes up with a headache, signs of increased intracranial pressure. So this time of onset is very, very important. A patient comes to you with worst headache of life. It started off a few minutes ago. Think of subarachnoid hemorrhage. Think of any abnormality inside. Family history. Migraine and cluster headaches are common in families. They carry the disease to the next generation. Factors influencing severity. For example, patients with migraine and cluster headaches, their pain gets away with sleeping or dark rooms, or in pregnancy, the attacks of migraines are much less often as compared to apart from the normal life. So these are the relieving factors in a patient with migraine who opts to sit in a dark room, because that's what makes that patient relax for some bit of time. Mass effects of lesions, especially if the suspicion of a mass in the brain, in the cranial cavity in the brain, which can cause headache. Coughing can exaggerate that headache. So these are signs of mass effect in the cranial cavity. Associated symptoms, which includes ear, nose pain, vomiting and nausea, are important. Seizures can be an associated symptoms. Neck rigidity and irritability can be an associated symptoms with headache and fever. Previous diagnostic test, any CT scan before, any radiological studies before, which demonstrated anything in the past, which can be a cause of headache for now as well, because of disease progression. These are important points to be asked from a patient. Location of the pain. It's a very, very important thing. because location of the pain can help you identify what type of pain it is. And a migraine pain, this is at times an ipsilateral, or half of the cranial cavity is involved, half of the brain is involved. While the tension headache, it's a diffuse or occipital or band-like at times. Mass lesions is often focal. A patient can tell you where the mass is, that's where the pain is. Trigeminal neuralgia, pain can present to you with stabbing, swear kind of pain in second and third division of trigeminal nerve. So migraine can present to you with half of the headache, half of the involvement of half of the head. While tension headache is a band-like headache, diffuse and occipital, or can be a band-like. Mass lesions are often focal, and trigeminal neuralgia, it's stabbing kind of pain, especially the nerves which supply with the second and the third nerve or trigeminal nerve, branches of trigeminal nerve. So quality of pain, what type of pain it is? It's dull kind of pain. It is stabbing kind of pain, as is trigeminal neuralgia. And migraine, it's throbbing kind of pain. Patient can tell you that someone is throbbed inside, that someone is squeezing inside from a brain. Tension headache is usually a steady headache. Trigeminal neuralgia, again, a shooting kind of headache, a stabbing kind of pain. So timings, mass lesions with headache, commonly maximum at when they wake up. So mass effect is common when the patient wakes up. Cluster headaches, on the other hand, can occur as the day progresses. They're asymptomatic when they wake up. So this diagram demonstrates multiple, as you can see here, this is a temporal headache. This is a diffuse headache. This can be a stabbing kind of pain with trigeminal neuralgia. This is also a diffuse kind of pain, focal pain. So moving on to physical examination. Physical examination is very, very important in patients with headache, because this can tell you a lot of information about what is the underlying disease that is causing the headache. For example, if a patient, check for vital signs, if a patient is presenting with fever and headache, think of meningitis or meningoencephalitis if the patient is drowsy or irritable, or the Glasgow Coma Scale is less as compared to the normal one. So if a patient comes to you with headache, also sensorium irritability with neck stiffness, think of meningitis. Think of meningoencephalitis. Blood pressure, especially in the patient with the hypertensive crisis, or patients with preeclampsia. Blood pressure is very important, but it's an often misconception that increase in blood pressure can cause headache. It is rare that itself increased blood pressure causes headache, until and unless that's a hypertensive emergency, where you can expect, or where the hypertensive emergency is when blood pressure is related to, and increased blood pressure is related to end organ damage. So that can present to you with headache. Skin examination, neurofibromas, or cafe au lait spots on Recklinghausen's disease can be seen in the underlying disease known as benign or malignant intracranial tumors. Cutaneous angiomas can accompany atriovenous malformations in the central nervous system. Scalp and head, look for in the temporal arteritis, look for nodularity or tenderness over the temporal area. Sinuses, look for any tenderness or erythema on the overlying skin over the sinuses or nasal discharge. Temporomandibular joints, look for tenderness and limitation of motions, and especially while chewing and other activities with temporomandibular joints. Orbits involve a bruit heard over the closed eye. Can suggest increase in intracranial atriovenous malformation. Neck and the back, Muscle spasm can present to you with headache. That's cervicogenic in nature. Meningeal signs, for example, signs of meningeal irritation, neck rigidity, fever, headache, these can be examined on physical examination of the neck and the back. Neurological examination, unilateral cranial nerve involvement, which includes focal neurology and some other things that are related to neurological examination, which includes sensory and motor losses. Moving on to cerebellar motor or reflex abnormalities. For example, a patient with stroke or intracranial bleed can present to you with headache and a signs of focal neurology. Miscellaneous physical findings, papilledema in a patient with headache and new onset of focal neurology can with papilledema, signs of mass effect. These are very important things and a very high yield to be dig out in a patient with headache because these at times can be life-threatening. So other miscellaneous physical findings that includes acute confusion and altered consciousness are the signs of patients presenting with subarachnoid hemorrhage and purulent meningitis. So moving on to some diagnostics testing, radiological studies, because why? Because when you're suspecting a brain injury or headache with some neurological deficit, you need to have a scan. You need to have a radiological scan because these are high yield and very effective and specific and sensitive to the disease that can tell you a lot of information about the underlying disease process. For example, you have CT scan. CT scan is widely used in especially patients with intracranial bleed, and especially for the first 12 to 24 hours. That can give you a lot of information. It's 90% specific and sensitive in the patients with intracranial bleed. Although it's very good in a patient with CVA, ischemic stroke, but MRI is diagnostic in these sort of patients. CT scan with leptomeningeal enhancement or MRI with leptomeningeal enhancement is high yield for meningitis and give you a diagnostic in a patient which you suspect of meningitis. It is important to identify what disease needs which type of scan, MRI or a CT scan. We will explain this when we talk about some neurological diseases which can come across with a headache. But first, at this point, I would like you to explain who are the patients that needs radiological studies when they present to you with emergency department. The patients with abnormal neurological signs, which includes altered mental status, for example, fever. These patients should undergo a radiological scan or imaging scan. Patients experience a new severe headache is an indication for a radiological scan or imaging. Patients who are immunocompromised or HIV present to you with headache is an indication for radiological studies. Moving on to some other diagnostic testing, for example, blood cultures, more importantly in a patients when you suspect a meningitis. Blood cultures and lumbar puncture cultures can yield much of the bacterial infections which can cause meningitis and can come up with a specific antibiotic for those bacterial infections. So these are high yield and can give you a lot of information and help you in treating the patient. Moving on to some complete blood count, which involves some white count which are increased in bacterial infections, but at times it's not increased, and viral meningoencephalitis, meningitis. Signs of anemia can present to you with headache, hematocrit, increased hematocrit. Signs of dehydration can present to you with headache. Moving on to erythrocyte sedimentation rate. It's an initial diagnostic test and when you patient with suspect of temporal arteritis. A patient, elderly male with sudden or with temporal pain that's throbbing in nature and can present to you with vision loss or blindness, unilateral blindness or headache. Erythrocyte sedimentation rate is an initial treatment because temporal artery biopsy takes time and it cannot be performed in emergency department. So erythrocyte sedimentation rate, if it's increased, and you suspect temporal arteritis, give IV prednisolone or IV steroids that can help to prevent the patient from becoming blind or visual loss. Moving on to carbon monoxide levels, very, very important in the patients who live in the same vicinity and present to you with some similar pains. especially in winters with headache and dizziness. Think of carbon monoxide poisoning. Carbon monoxide poisoning, pulse oximetry is not always the therapeutic, because why? That might show 100% saturation rate, but at times the patient is not getting enough oxygen. Moving on to pulse oximetry and ABGs. ABGs, arterial blood gas, is important for any respiratory or metabolic disorders that can present to you with headache or altered mental status. Serum electrolytes, electrolyte abnormalities can present with headache. The signs of dehydration or excessive water loss, or vomiting or nausea excessive vomiting or nausea or diarrhea can present with headache because of fluid loss. CSF analysis in a patient with suspected meningitis or subarachnoid hemorrhage can help you make the diagnosis and help you in treating the patient. Let's talk about some general treatment options that an emergency physician have while dealing with some common problems which involves headache. Let's start off with migraines. First option we have is NSAIDs, which includes ibuprofen, naproxen, ketorolac, or indomethacin. These are all used for mild to moderate migraines. They all can cause gastrointestinal problems. Next is dihydroergotamine and sumatriptan. These are serotonin agonists. These are used in patients with moderate to severe headache. These can be used intramuscular or subcutaneously. Next is dopamine antagonist, that's prochlorperazine or chlorpromazine. These are used in moderate to severe headache. Metoclopramide can be used in moderate to severe headache. Ketorolac, morphine, and hydromorphone can be used in patients with severe or unbearable headache. IV 30 milligram of ketorolac, that's an NSAID by itself. Morphine, that's an opioid, can help relieve the pain. And patients, despite of adequate or the patient with severe pain, IV dihydroergotamine is also a good option. So with cluster headaches, high flow oxygen, subcutaneous sumatriptan, parenteral dihydroergotamine, it's a serotonin agonist, intranasal lidocaine, not widely used now, but it is effective at times, and steroids. So with cluster headaches, simple, these patients can present to you with similar pains, with similar complaints again and again. You have to identify the life-threatening causes. With cluster headaches, these are chronic pains. This is not life-threatening. What to do? Give oxygen, high-flow oxygen, subcutaneous sumatriptans, parenteral dihydroergotamine, that's serotonin agonist, intranasal lidocaine, or steroids. Tension or cervicogenic headaches, which involve analgesics, which analgesics explained before, which includes NSAIDs, non-steroid anti-inflammatory drugs, which includes ibuprofen, ketorolac, and indomethacin. Next would be some opioids or IV NSAIDs can be used in patients with tension or cervicogenic headaches. So analgesia is important. Let me remind you one thing. If a patient comes to you with headache, instead of asking or examining the patient, first and the foremost thing you have to do is analgesia and pain management. First, make the patient comfortable, then proceed for examination and other relevant investigations. Ice is effective in patients with tension and cervicogenic headaches. Relaxation techniques could be used in patients with tension and cervicogenic headaches. Trigger point injections are also used for these headaches. So moving on to subarachnoid hemorrhage. Subarachnoid hemorrhage is a life-threatening problem. It can happen when a patient presents to you with worst headache of life, new acute onset of headache. This can present with, these are the symptoms of subarachnoid hemorrhage. But the mainstay of treatment before going into the neurosurgical consultation and further involvement of the subspecialties, first you need to identify and resuscitate the patient. Is the airway patent? Is the breathing symmetrical or adequate? And is the circulation perfuse? So A, B, C is vital things that you need to identify, you need to stabilize first before going into further investigations and treatment. Then the next thing you should do is an urgent neurosurgical consultation. So moving on to subarachnoid hemorrhage, the mainstay of treatment or the goal of treatment is to prevent from recurrent bleeding and to prevent the patient from ischemic stroke, and also to address the neurological problems that the patient had with subarachnoid hemorrhage. So with rebleed, the first thing you would do is try for early aneurysm closure. If not possible, try antifibrinolytic therapy. Subarachnoid hemorrhage with vasospasmic activity, patients can present to you with, there is a chance of increased or uncontrolled hypertension in a patient with subarachnoid hemorrhage. So you have to control the blood pressure, because it can cause ischemic stroke. How do you do that? Prevention is by nimodipine, or for high-risk patients, consider statins. With symptomatic vasospasm, neurosurgical intervention is required, and the patient can be with hypervolemia. Hydrocephalus, if the patient is with symptomatic hydrocephalus, that's increased intracranial pressure or increased intraocular pressure. Signs of increased intracranial pressure and intraocular pressure. This patient needs CSF drainage and CSF pressure monitoring. Epidural and subdural. Surgical evacuation is the treatment of choice in a patient with epidural and subdural. Coagulation of the bleeding site is also used in patients with epidural and subdural hematomas. Giant cell arteritis, again, if a patient, elderly male, comes to you with right-sided or temporal pain, with noding or a tender nodular feeling on the temporal side, with blurring of vision or vision loss, think of giant cell arteritis. But before the diagnostic or the most important diagnostic study to be done in a patient with giant cell arteritis is biopsy, but that could not be done in ear. So erythrocyte sedimentation rate is a initial treatment recommended test of diagnosis, and the treatment should be started within no time. That's IV prednisolone or tablet prednisolone. Why? Because it can prevent the patient from blindness. Idiopathic intracranial pressure, acetylzonamide can be used. Furosemide can lower the intracranial pressure, intracranial hypertensive pressure. And steroids, dexamethasone, can be used in these patients. Other causes include tumor headache, hypertensive steroids, because tumor with the patient with a tumor or terminal case diseases, they have increased pain feelings. Why so? Because of terminal diseases. And these patients need hypertension and analgesics and hypertensive steroids. And these needs dual or triple analgesics or analgesic therapy for the pain management. Tumor headache involves, which can be treated with hypertensive steroids. Phenytoin could be used, valproic acid, if a patient can present to you with fits due to the tumor progression or a mass effect, and carbamazepine could be used in these patients. Meningitis, broad spectrum antibiotics, which covers viral and bacterial infections, until unless the cultures come out. IV steroids, dexamethasone is used, and that's 0.15 milligram per kg in adults. Acute angle glaucoma, topical beta blockers, oral or IV acetazolamide. Miotics could be used in these patients, and these patients also need an urgent ophthalmologist on call. Trigeminal neuralgia, stabbing kind of pain, especially in the second and the third division of the trigeminal nerve. Carbamazepine is used in these patients. Phenytoin and baclofen is used to treat the pain that's caused by trigeminal neuralgia. Post-dural puncture, hydration is very, very important. Bed rest and analgesia. Oral or IV caffeine. IV caffeine is used at times for the management of post-dural punctures. Epidural blood patch could be used as well. Carbon monoxide poisoning, 100% of oxygen. If the patient is with decreased oxygen saturation or the patient presents you with signs of headache and dizziness, this patient is hyperbaric oxygen therapy. Carotid and vertebral artery dissection, anticoagulation, followed by antiplatelet therapy, and urgent vascular surgeon on call should be called on for further management. So let's talk about some special patients. In pediatrics, headache is very common in pediatric population, especially in ages of more than or 7 to 15. The most common cause of headache in patients from 7 to 15 is migraine. But being an emergency physician, you have to rule out the life-threatening problems in a pediatric population. So you have to look for a meningitis. Well, meningitis present to you with, in pediatric population, meningitis present to you with irritability, decreased oral intake, irritable behavior, crying, excessive crying, or drowsiness. While pediatric population can present to you with subarachnoid hemorrhage. Ask from the mother or the caregiver about the recent events that causes this headache. High blood pressure can cause headache, but that's rare in pediatric population. So when pediatric population, think of meningitis, subarachnoid hemorrhage, and migraine attacks, because these are common in pediatric population. Or moving on to elderly population have low threshold for an excessive workup. Why is so? Because of chronic changes that are going through in the mind with the progression of the age. There is increased chances of subarachnoid hemorrhage. There are increased chances of subdural hematomas. At times, elderly patients are dementia. They don't know the history of the past, past history of fall or any event that led to this headache. So these patients warrant an higher investigations and have low threshold for a CT scan and other investigations that to be done in these population. Immunocompromised, these can present with similar complaints or similar type of diseases that occur in the normal individual, but patients who are immunocompromised are prone to get infected from various infections, for example, toxoplasmosis, cytomegalovirus, virus, Haemophilus influenza, and many more bacterial and viral infection that can cause meningitis and worsening headache in these patients. Pregnant female, muscle contraction is the most important cause of headache in these patients. On the other hand, the good thing is in patients who are known case of migraine and are pregnant, 80% of the patient go into remission during the pregnancy. But on the other hand, the bad news is the tumor. If there is any tumor inside the brain, that increases in size during pregnancy. There are 10% chances of subarachnoid hemorrhage in pregnant females, and there are chances of pseudotumor or idiopathic hypertensive crisis in pregnant females with that present to you with headache. Look for signs of preeclampsia and eclampsia in these patients with hypertension, headache, and see a fetal-like activity. Think of eclampsia and preeclampsia. These patients should be dealt carefully and should be given enough analgesia to maintain and keep longer in a pain-free environment. So this is a very important slide. Indication for hospitalizing the patient with headache. At times, headache, it's difficult as an emergency physician to differentiate if this patient having a headache due to any life-threatening or a serious complication, because headache is at times very difficult to diagnose or to differentiate. So many people who come up with headache are almost, or many of them are admitted for further management. So what are the indications for hospitalization of the patient with headache? Central nervous system infections, which involve meningitis and meningoencephalitis. Vascular diseases, subarachnoid hemorrhage, AV malformation, or rupture of the Barry aneurysm, which are important in females who are pregnant in the second trimester of the intracranial bleed due to Barry aneurysm. Subarachnoid hemorrhage, cerebral ischemia, severe hypertension, spontaneous carotid artery dissection, and temporal arteritis. Space occupying lesions, especially patients with known case of tumor or have no prior history of any tumor or a mass effect, can need admission and further management and further investigation of what type of mass or space occupying lesion it is. It can be a bacterial abscess, especially in tuberculosis granuloma. It can be some other abscess due to any other infection that's occupying the space in the cranial cavity. Toxic metabolic encephalopathy, patients with carbon monoxide poisoning, they should be put under observation in hospitalization until and unless they are proven safe to go home. Any patients with increased drug intake or toxins intake, think of any life-threatening injuries underlying, and that patient should be hospitalized for observation and further management. Idiopathic intracranial hypertension not responding to the usual measures. So what to do? Hospitalize the patient if the patient's functional capacity is uncompromised. Hospitalize, admit the patient, observe the patient, and send home when the patient is safe to go home. Headache associated with severe medical illness. For example, meningitis, meningoencephalitis, subarachnoid hemorrhage, subdural hematomas, space-occupying lesions, mass effect in the brain, drowsiness. These are the symptoms, these are the headache that can present to you with severe medical illness and that needs hospitalization. Severe intractable headache, worst headache of life. Think of subarachnoid hemorrhage. These patient needs admission. Continuous vomiting, electrolyte abnormalities, or inability to maintain oral hydration. These are also the indicators for a patient to be hospitalized, because if the patient is not eating or if the patient cannot take orally, this patient needs IV fluid, this patient needs IV antiemetics for the management and further preventing the patient from further electrolyte depletion and volume depletion because of vomiting and other problems. Complex drug interactions. These patients should be admitted in the hospital. Social situation, preventing appropriate outpatient management. There are some cultural differences or cultural limitations. A patient cannot differentiate or cannot acquire the outpatient care that he or she can acquire within the hospital. So this patient should be admitted in the hospital because of some social or cultural limitations. So in this lecture, at the end, I would like to summarize this for you, what we have studied till now. We studied the acute headache. What type of headache do we get in emergency department? What are the life-threatening problems that can cause headache, and what to look for in a patient with headache or worst headache of life? How to approach a patient with headache, what questions you need to ask in a patient with headache, probing out the life-threatening problems, what radiological studies should be done in these patients for specific diseases that involve headache, what are the treatment options or analgesic options that we have for some common diseases that present to you in emergency department, and what are the criteria or what are the differences in a patient or special patients, which includes pregnant females, which includes pediatric population, geriatric population, and immunocompromised. And last was about who needs admission and what is the criteria or indicators that patient should be admitted in the hospital. And that's all for now. Thanks for watching.